I am going to talk to you about a not so very uncommon problem, that is cervical OPLL and decision making in cervical OPLL. Why is my presentation not moving further? Okay. So no disclosures at the outset, only disclosures are teachers, Professor Ramani and Dr. Sontag, from whom I learned certain aspects of spinal surgery. So OPLL is nothing else but ossification of the ligament behind the vertebral body. And excessive ossification, for what reason unknown, maybe some genetic defect in chromosome 6. And there are two problems. One is the compression, and the second one is the deep stretch strain. It is not just static compression, but compression along with the instability, which gives rise to this neurological syndrome and the various symptoms of OPLL. It is an East Asian disease. Maybe it is an abnormal attempt for stabilization. There is an abnormal attempt, but why it occurs only in the posterior longitudinal ligament, still there is no evidence. They say that there are some cells in the posterior longitudinal ligaments which are affected by maybe hormones, maybe by blood sugar, and they show excessive ossification which goes out of hand. So it is a kind of a keloid of the posterior longitudinal ligament. Of course, there are classifications which are important to know for decision making: the continuous type, the segmental type, the mixed type, and the focal type. And also on axial section, it is important to know that there is a square type, there is a hill type, and there is a mushroom type. And the mushroom, this is important because those who attempt surgery should know that how this OPL is going to behave during surgery and how you are going to, because the spinal cord can be stretched over the mushroom, and it is very easy to damage the dura when you are trying to remove a mushroom type as compared to a hill type. This is the easiest type of OPLL. Also, presence of a shadow within the OPLL means that there is a dense attachment to the dura. So having knowledge of these things before on imaging are very important. So this is how the linear type, the crescent type, and the mushroom type would look on axial sections, and their knowledge to be pre-warned is to be forearmed. Now, what kind of operation can be done and when it is required, the operation? We have to remember, we must understand the natural history before advising surgery. 17% of asymptomatic patients will eventually develop myelopathy, and 64% having clinical signs at the time of diagnosis will require surgery. The excellent work of Madhasunga has given us that if there is a signal change in the cord, then maybe it is wiser to advise surgery rather than to wait for neurological deterioration. So you see, this is a patient who has got an OPLL with the mild changes and operated earlier. The cord migrates and there are no gross deficit. But a person who is already having severe signal changes and delay operation, then even if you do a good decompression, the cord migrates backwards, but still you will see that the myelomalacic changes may even progress after surgery and the patient can worsen. There is a paradox in understanding this OPLL. That OPLL, I'm getting somebody's sound inside. Somebody talking in the background. Okay. So OPLL, one important thing is that more extensive the OPLL, more the lordotic the spine. And more lordotic the spine, the better are the chances for posterior decompression. So you see that OPLL, if it is extensive and more extensive superiorly, inferiorly, you will find that the curvature of the spine remains either neutral or lordotic and rarely becomes hyper. This is another example. So compression or instability, you have to decide what is the main problem. In this kind of patient with a neutral spine, the main problem is just the compression over here. There is hardly ever instability because the spine has gone on to get autofused. So you see the evolution of surgery. What happened that in the Western literature, everybody had focused on anterior surgery. And mind you, this was in the 90s and 80s when good implants had yet to come. And therefore, the complication rates of anterior surgery were very high, and people started looking towards a posterior option. It remained for Hirabayashi somewhere way back in 1981 to describe the operation of posterior decompression. Of course, subsequently, many other people described it. The technique was simple, that is dividing the lamina on one side, making a gutter on the other side, and then tilting the spinous process to the opposite side and maybe fixing with a plate or sutures and expanding the spinal cord. This worked because of one very important thing, that as the OPLL grew, the cord was pushed backwards and the tether of the cord, that is the denticulate ligaments, had already stretched. And therefore, when you expanded the spinal canal, Dr. Mehrotra, there's somebody speaking in the background, and that is, I'm getting that sound. Is there somebody's audio which is on?
Yes, sir, we have muted. Sir, we have muted everybody now. You can please go ahead, sir.
Thank you. So this is how it works, and this is how the spinal canal is expanded, and the denticulate ligament is already stretched, so it helps in the cord to migrate backwards. The other option, of course, is to do a laminectomy. And then people came out with muscle splitting, division of the spinous process, etc., to expand the spinal canal. Various ways to skin a cat, various ways. And then you get an expand. You find that the cord moves backward and the subarachnoid space gets widened in the front in spite of significant compression. And that is because of the paradox of the stretched denticulate ligaments. The problem with laminectomy was that ultimately laminectomy ends in some amount of kyphotic deformity. So posterior approaches, you have laminectomy, laminoplasty with laminoplasty with lateral mass fixation. The advantage of laminectomy is quick, minimal blood loss, minimal technology, fast learning curve, but definitely there is a worsening over a period of time. Laminoplasty, posterior elements are preserved. Laminectomy, membrane can be prevented, restricts motion. Decompression effects are similar to laminectomy. So this is an example, you can see this, that the entire spinal canal gets widened. Laminoplasty has got problems, it's not without problems. There's neck pain, there's progression of myelopathy, there's partial relief from radiculopathy. And you'll find that if you really find that there's not much difference between laminectomy and laminoplasty. The review of the laminoplasty is as unstable as laminectomy. So the reason why it was being sold itself is not valid. And you'll find that there is enough evidence in literature that there is no difference between laminectomy and laminoplasty. Spinal alignment, kyphosis relates to poor outcome, disease progression occurs in spite of decompression, and therefore good gardening is the key for good fusion. And I'll draw your attention to my friend's work, Dr. Muthu Kumar in 2016, Neurology India, where I think at this point in time, a good decompression with reconstruction of the lordosis using lateral mass fixation is one of the best options if one is considering posterior surgery. The other advantage is that you have got an opportunity to do root decompression, because many times these patients are not just myelopathy but myeloradiculopathy. And the problem is that if you do not decompress the roots properly, there is a known complication which is the C5 root palsy, which gets taken care of by this kind of operation. Of course, I have also published my work for the juniors who are interested in reading how the surgery evolved and what should be done, how to select the operation. You can refer to this. So these are some examples you can see with bad OPLL. You do a laminoplasty, or even in elderly patients, a quick laminectomy, you can get a good decompression as long as the curvature of the spine is maintained. And you'll find that in extensive OPLL, always the spine is already immobilized and the lordosis is already there. You have to remember that OPLL is not a disease which is static. This was a patient who had been operated initially, then decompressed, laminectomy done, then 2016. You see the OPLL is progressive in spite of a good decompression. And now in 2018, the patient comes with very extensive OPLL going right down up to the dorsal region. So this is a disease which does not stop with decompression. So if you are accepting the theory of instability, then immobilization is mandatory if you are trying to treat OPLL. Of course, sagittal balance became very important, and you heard Dr. Manas Panigray's talk. So the selection in criteria is that the maintaining the sagittal balance, the most important thing considered was the K line, that is a line drawn in the center of the axis to the C7, and whether the OPLL mass is anterior. If the OPLL mass is anterior to the K line, it's a good case for anterior surgery. But if the occupation of the canal is more than 60% and the mass is behind the K line, then the posterior surgery is not going to help the patient. There are various concepts which are used in making the decision in OPLL surgery, and canal occupation is, of course, a very important aspect. So the aims are what? Neural decompression, maintaining spinal alignment, and successful fixation and fusion. Anterior surgery, various studies have shown that anterior surgeries have got better result as compared to posterior surgery, but over a period of time, it squares off and does not make much difference after 5 years, whether you have done an anterior surgery or posterior surgery. You have to consider another very important factor in when doing these surgeries is that we just go by literature, but we have to consider individual skill and individual facilities available for doing so. The complication rates increase with duration of operation, with the amount of blood loss, the amount of technology available to you for doing surgery. Anterior surgery has various problems like graft issues, CSF leaks, graft site problems, recurrent laryngeal nerve injury, as compared to posterior surgery, which is very easy. The only really significant complication in posterior surgery is C5 root palsy. Anterior surgery has various other injuries to the surrounding structures. I'm not against anterior surgery. I do a lot of anterior surgery. But in OPLL, you have to be careful. So the overall morbidity risk associated with corpectomy is between 11% to 27%. And anterior surgery is a technically demanding surgery. Anterior plating and gardening has to be done properly. I saw the videos on corpectomy and discectomy. One of the focus while doing anterior surgery is to get a good fusion. And that good fusion is not done just by removing bone, but also by preparing the adjacent vertebra. Otherwise, there is going to be graft subsidence, and that is going to have load on the plate. I have also written about it in this chapter. So the rate of complications in CSF leaf graft extrusion income was 23%, and approximately half of these 23% required second surgery. So it is not a very minor operation. There are various options and it should not make life confusing. I find that this trade-off of posterior surgery is very good. Of course, you can, if you do a good anterior surgery, maintain the lordosis, get a good fusion, you can have equally good result. But this surgery is more technically demanding than this surgery. Doing an anterior decompression is not very easy operation. It may look simple, but if not done properly, you'll add insult to injury. So there are some examples, this OPLL, if done properly, decompress, this patient also had radiculopathy, you get good lateral mass fixation and decompression. Cervical laminoplasty was devised to avoid the problems associated with laminectomy, such as postoperative segmental instability, kyphosis, perineural adhesion, and late neurological evidence. But there is hardly any evidence to support that. Hardly any evidence. Now, see, this is an example who underwent this is a patient, and you can see flexion extension. Even there is some element of instability. So, good decompression and lateral mass fixation definitely arrest the progress of the OPLL. Otherwise, you do a good decompression, you get initial benefit, and as the kyphosis progresses, the patient worsens again. So, anterior versus posterior surgery, you see that they have done a large review from 1990 to 2013. There is very little level 1 evidence to say that anterior surgery is better or posterior surgery is better. There is no apparent difference. Higher rates of surgery-related complications and reoperation are seen in anterior surgery. Again, another large analysis from 1995 to 2015, safer with lower surgical trauma, posterior surgery. So the argument is tilting more and more towards posterior surgery. So there is only one randomized control study comparing laminectomy, fusion, laminoplasty, and showed similar neurological outcome. There are no randomized control trials comparing each operative option in cervical OPLL. So everybody is doing what they want to do. Now this kind of case, see, this is a cage. I am very much against these distractable cages, because distractable cages, you fill the bone inside the distractable cage, and once you distract that cage, that bone is floating. So you're never going to get fusion. You're going to rely on the implant for the rest of your life. So a mesh cage is far superior, packed with a lot of bone, which ultimately is going to fuse with the vertebra above and the vertebra below, rather than a distractable. This is another example. This is now the trade-off is to get a distractable cage with a plate fixation. But I think this is an inferior implant, because the bone graft which you put inside just keeps on floating. After some time, it disappears, and you can see this kind of resorption of bone which you have packed inside the cage, which is of no use. The mesh cage, of course, is very, very good option when you are treating OPLL or doing anterior multi-level corpectomies. Another important thing in OPLL is that you have to remember that you have to always go beyond the OPLL if you want to get a good decompression. Just trying to remove what you see over and get a dura, you'll never get decompression. You have to plan the surgery by studying the CT scan very properly. The MRI is very poor. The CT scan should be studied to decide how much decompression you want to do. And then lift up the OPLL, sometimes leave a very thin layer, and probably there can be always difference in opinion, because I do not believe that we should take the drill right down to the dura, because the incidence of dural tear can increase. So these are examples. You can see another patient with a lot of bone graft inside and with fusion. The Waterloo for anterior surgery is OPLL adherence to dura and interference with cord circulation. People have done intra-op CT scans also to confirm whether they have done good decompression. I devised a technique which I was showing from the year 2015 to avoid this problem of dural rent and during decompression. The technique was simple, which involved exposing the spine like always. We all are aware of it, how to expose the spine. And then you go up to the uncinate process, and you go up to the uncinate process, and you can see this. This is the OPLL. With a micro drill, you first decompress the vertebral body up to about 50%. 50%. Then the uncinate, at this level, you make use of a bone saw. You can even use a micro drill to reach this is very good for hill type of OPLL. You go right up to the dura. The last part you can even cut off with a kerrison punch. You can use a 2 mm drill to do that. The discectomies are done on both sides, of course. You must curate and get bleeding bone from both the end plates before you put bone graft inside. That is the most vital step of anterior surgery, is to have bleeding bone from either vertebral edges. Then put a plate. This is specially made for me by Jeon company. You can use any plate, but Jeon had made the screws for me where you dial the screw, and as you put a nut, the vertebra is pulled up, and you break off. So the vertebra with the OPLL is pulled anteriorly, and the cord is decompressed. As you tighten the nuts, so you can see this case of OPLL, and the spinal canal is narrow here at 8.6 mm. And then the patient also, you can see this OPLL, and then you can see post-surgery, the spinal canal is widened to 11 mm because OPLL has got pulled up with the vertebra, and this is a long-term result which shows you good fusion. This is a case of cervical spondylosis, this treated by the Sigma operation, and the vertebral bodies have been pulled forward. Now, this is a pictorial description of how to do it, making the vertebra half, then putting the screw plates and pulling the vertebra until I'm sure most of you must have understood what I'm doing. And yes, it was a good operation, but it is good for only hill type of cases where, you can reach the dura very easily. For the square OPL extending to the foramen, you cannot do this operation. And over a period of time, I realized that if there is radiculopathy, then this operation is not very good. Now, what happened is that I was showing this from 2000. I showed this even in 2016. And then suddenly 2018, there is a paper which describes the technique from another part of the world. My friend Ketan, I'm very sorry, he passed away in a car accident. He was, one of my, like my brother, and who helped in most of my cases. And immediately there was a letter to me from Ajay Prasad from Gandha Hospital that somebody has hijacked your technique. But I wrote to them that it's not important. Many people can get the same thought simultaneously in the world, And it is not important to be pioneer, but it is important to evolve the technique and make it better and better. So maybe somebody got the thought, maybe somebody saw my presentation, but anyway, I don't think that is important. So there are many other people who devise newer ways of doing it. So this is making use of a plate to pull the entire aspect. But these are not easy things, They look very simple, but they are not easy. Similarly, somebody decided of putting bone grafts and reconstructing the wedge and reconstructing the lordosis. And my friend Atul says that you fix C1, C2 and OPLL will disappear. So a lot of thoughts and various kinds of options. So this is a new way where you do posterior decompression. In addition to that, you put interbody grafts which are wedge shaped and reconstruct the lordosis and make a new K line by getting the OPLL mass in the anteriorly. I have done a few of these cases. Again, I tell you that these are not easy because to get this break behind is not easy. To reach all the way up to the dura at every level is not an easy operation. So these are some examples you can see where you do the posterior surgery and do the anterior surgery and put the wedges inside. This is a textbook, but this is not my case. This is from the book I've picked up. So OPLL, where the occupation ratio is more than 60%, anterior surgery is superior. Those with, some people say more with 50%, there are more complications with anterior surgery. Whatever it is, there are various ways, but it's the end of the means that matter. But there's all the evidence in OPLL surgery is level 3 evidence. Most important, I think, is the medical fitness, your individual surgical skill, and the level of technology available to you. Don't get impressed by what is given in literature. Laminectomy is a very simple operation. Laminectomy with lateral mass may be slightly more difficult, but you have to decide and tailor the operation as per the patient's requirements. And now, even in 2020, 21, still the jury is out. There is no evidence still in favor of anterior surgery or posterior surgery. So ultimately, you have to decide what you can do and what your patient can tolerate. Sometimes you get confused with dish. Now, this is an example of a patient who had, it looks like OPLL, but the more important part, this is a very interesting patient who was having difficulty to swallow, and then we had to decompress and put a bone graft, and this can mimic OPLL, but they are not OPLL. Anterior surgery and posterior surgery probably is required in some cases, but then there are some patients who are best left alone. Thank you, my dear friends.